Hello everyone, I'm Jon Salmanton-García from the University Hospital of Cologne in Germany, and today I would like to present you the last results from the EPICOVIDEHA registry, B-cell malignancies treated with targeted drugs and SARS-CoV-2 infection. These are my disclosures. First of all, as a brief introduction, as you all may know, EPICOVIDEHA is an international registry for COVID-19 patients with baseline hematological malignancies. It's a retrospective study where we collect cases since the very beginning of the pandemic, and we do it in a continuous manner. Still, we are recruiting patients, but only once they have finalized their COVID-19 episode. And this is also very important. It's a collaborative effort as we provide authorships and collaboratorships to all the contributors whenever their patients are included into an analysis, with more than 150 contributing institutions in more than 40 countries all around the world. Now, specifically about the patients included in this manuscript, we can say that patients with B-cell malignancies, as you all may know, are especially vulnerable for SARS-CoV-2 infection. And this is due to their impaired immune response to pathogens and vaccines because of their hypogammaglobulinemia, their qualitative and quantitative B and T cell defects, and also their innate immune dysfunction and neutropenia. In this case, we are speaking about patients receiving targeted agents, and in this case, targeted agents in the treatment of B-cell malignancies have changed their management, and therefore the targeted drugs differ from conventional chemotherapy regarding the risk for infection. Specifically about COVID-19, there is evidence of high rate of severity and mortality in CLL patients, and also that there is an impaired serologic response after 12 months of treatment with anti-BCL2, anti-CD20, and patients receiving TKIs. But there are limited data available on the clinical course of COVID-19 in B-cell malignancies treated with these targeted drugs. Therefore, our main goal in this analysis was to describe COVID-19 outcome in patients with B-cell malignancies that were previously treated with targeted drugs. The inclusion criteria were age over 18 years old, and a positive SARS-CoV-2 test, active CLL or NHL at any stage or status, and the previous reception or administration of targeted drugs for malignancy treatment. In total, we collected details of 366 patients, 55% were CLL, 44 NHL, a median age of 68 years old, and 60% of males. Only 33% of the sample had 2 or more comorbidities, and only 16% received 2 or more SARS-CoV-2 vaccine doses at the onset of COVID-19. In total, 75% of the total number of patients were hospitalized at any moment during the COVID-19 episode, and they stayed in hospital for a median of 16 days. In this table, we can observe how was the patient distribution based on which targeted drugs they received before COVID-19. We have 55% of patients receiving TKIs alone or combined with other drugs, 16% of patients receiving anti-CD20 alone or combined, and 9% receiving BCL2. The rest of the patients received other targeted drugs. And which are the factors associated to severe COVID-19? Well, severe COVID-19 was observed in 48% of the analyzed samples, and 44% need to receive invasive mechanical ventilation. And overall, they stayed in the ICU for a median of 9 days. There was a presence of comorbidities associated with severe COVID-19 infection being statistically significant in the entire cohort in patients only with CLL, only with NHL, and also in patients receiving TKIs. Severe infection was also more prevalent in the first as compared to more recent COVID-19 waves, and this was also statistically significant, but we didn't observe any association in favor of severe COVID-19 due to age, type of targeted drug therapy, or time from last hematological malignancy treatment to COVID-19 onset. And there was neither any significant risk factor for severe COVID-19 in patients receiving BCL2 or anti-CD20 monoclonal antibodies. Regarding factors associated to mortality, at day 30 since COVID-19 onset, we observed a 25% mortality rate, which raised until 37% in the last day of follow-up. Regarding the mortality rate in the last day of follow-up, almost 70% of the patients died due to COVID-19, only COVID-19, 10% due to the baseline malignancy, and 21% due to a combination of both COVID-19 and the malignancy. And overall, they were follow-up for a median of 71 days since COVID-19 onset. If we look specific mortalities, we can observe how ICU mortality overall was 66%, 62 in the case of CLL and 76 in the case of NHL. Regarding the number of vaccine doses administered, we have 39% of mortality rate in patients unvaccinated, 31% in patients with 1 dose, 25% in patients with 2 doses, and 20% in patients with 3 doses. And regarding the different pandemic waves, 41% mortality rate in the first semester of 2020, 25% mortality rate in the last semester of 2021. Additionally, we ran a Cox regression analysis in order to determine which are the factors associated or the factors that could explain the mortality in our patients. And in the multivariable model, we observe how an increased age, the presence of an active malignancy at COVID-19 onset, and severe and critical COVID-19 were associated to mortality. Additionally, we also ran survival plots, and we can observe now the Kaplan-Meier survival plots, and we did not observe any difference, any statistically actually significant difference in the survival probability based on the number of vaccine doses. We did observe based on the age of the patients, and no differences based on the baseline malignancy, chronic lymphoid leukemia versus non-Hodgkin lymphoma, or in the case of patients receiving or not TKIs for the malignancy treatment. With this, we can conclude that we are presenting here the largest B-cell malignancy patient sample of patients actually under targeted malignancy treatment and COVID-19. And it's especially important because of their long follow-up and because they are real-world data that provide evidence for increased severe disease and mortality. Targeted drugs, we did not observe them to have an impact in the survival of the patients, and we did observe which were the patients at a high risk for mortality, patients over 75 years old, patients with previous comorbidities, for example, heart or renal disease, and patients with an active malignancy at COVID-19 onset. Vaccination is key because it's protective for mortality, even if in this population, due to the humoral immunity impairment, the results are not that significant. And finally, last but not least, we could observe how the pandemic evolution based on the acquirement of knowledge from the healthcare workers shows benefits for the management of these patients. I would like to finish with an acknowledgement to all the researchers participated in this research, and just a reminder, in case you want to contribute your cases to the EPICOVIDEHA registry, please feel free to send us an email or to contact us via Twitter. Thank you very much, and see you next time.